Hi, this is Brian Kim. I want to share with you two cases using the SimulEYE IOL fixation model. And I'm going to be performing the Kim modified Yamane technique, showing the trailing haptic first modification using the JnJ Sensar AR40 lens. As most of you know, the Yamane technique requires a lot of manipulation of the haptics. And in this case, the polyvanillidine fluoride haptics with the CT Lucia 602 lens from Zeiss is kind of the ideal lens we use in the United States. There was a time where that lens wasn't readily available. And so either you had to abandon the technique or try it on different lenses. And so I've been using it on the Sensar lens, and the Sensar lens has really delicate PMMA haptics. And so as I've been doing this technique, I've realized a couple of things. With the original technique, using PMMA haptic lenses requires a lot of manipulation, and as a result, it can cause damage or breaking of the haptics. And so as I've been using my modified technique, I realized not only is it easier to cannulate the trailing haptic, making it less ergonomically difficult and awkward, but it's actually much more gentle on the haptics, a much more gentle technique, less tension, less manipulation, and as a result, less likely to cause warpage, damage, kinking, or breaking of these haptics. And so this is why I'm going to show you these two cases doing the modified Yamane technique with the Sensar lens. So this is the model. This is the SimulEYE iris suturing and IOL fixation model, as you see here. I want to thank the folks at SimulEYE for letting me use this model. And this is the first needle. It's going to be the right needle. It's bent about 9 millimeters from the tip, angled about 70 to 80 degrees, and the bevel is facing towards me. This is the left side needle. I'm going to bend it at the hub. And I'm going to make sure that the bevel is facing away from me. And the facing of the bevel is going to be facing the approach of the haptic. And here I'm going to make my contralateral limbal incision, and that's going to be for the externalization of the leading haptic. And this is the 3 millimeter keratome blade for the main incision for the IOL. First of all, look how beautiful this model eye is. You can see the anatomy so clearly. It's just well controlled. And as a result, it's really an excellent teaching tool for new techniques like this. So we'll go ahead and place a 25 gauge needle through the contralateral incision. And what that's going to do is going to be a very gentle way to externalize the haptic. I don't have to grab it, which can actually damage the tip of the haptic. What it's going to do is going to dock the haptic on the bevel of that 25 gauge needle. And as the lens is advanced, it just slides right out. And so that's kind of a new modification that I've come up with this trailing haptic first technique and externalizing that leading haptic. Go ahead and start to deliver the optic myself. And as I do this, I want to make sure that the optic comes out planar, and then make sure that the trailing haptic comes out pointed towards the right for the proper orientation. But as I do this, I realize that I should have put the incision right there. That's what I'm showing with my forceps, because the lens is more towards the left when I have the leading haptic a little bit off center. And so what I'm doing is internalizing that haptic, and then I re-externalize it so that the contralateral incision is 180 degrees away from the main incision. Go ahead and place the needle through the sclera, and look how easy the visualization. There's no tension on the haptic, there's no torquing, there's no distortion. It's very, very atraumatic. It's a very smooth pass. And so this is, again, why I like the trailing haptic first technique, which works in particular very well with the Sensar lens. The curvature of the haptic with the Sensar is very similar to the curvature of the CT Lucia lens. It's not a extreme curvature of the haptic, which is, which you see more with the MA60 AC from Alcon. So go ahead and internalize the leading haptic into the anterior chamber here. And again, you want to be very gentle on the tip of the haptic. And these haptics are very, very, very delicate. I'm using the needle there to find 180 degrees apart. Go ahead and place the needle through the scleral tunnel 2 millimeters and then dive down. You can see the bevel is facing away, which is going to face the approach of the haptic. So look, you see the haptic is somewhat perpendicular, but I'm going to dock it on the bevel of the needle, which allows it to straighten out. And once I get it docked there, you see it's able to capture the haptic on the bevel. And then I just straighten it out and just very gently go ahead and place it through. So you saw how easy that maneuver was. Go ahead and pull each needle out. And as I pull each needle out, I'm going to do a simultaneous externalization. And as I pull each needle out, each haptic comes out. What's interesting about the PMMA haptics on the Sensar, they're actually, when you try to cannulate the haptic through the needle, it's quite a bit of a tight fit. And it's a little bit different from the CT Lucia haptics. Those haptics tend to be a little bit more loose within the shaft of the 30 gauge thin walled needle. However, these PMMA haptics on the Sensar are actually have a lot more friction. So in other words, less likely to slip. So you will look at the eye well centration, the haptics are well centered. And all I'm showing here is after you're done with the technique, you can go ahead and push the haptics into the eye, and then basically you can pull the haptics through on the inside, and it's basically a brand new case. So this is a second model eye. In this case, I'm actually going to mark every single incision, every single mark that I use for the needle placement for much more clear educational purposes. I didn't do that on that first case. That was kind of like a dry run. And so you can see by marking, it's going to make it a little bit more clear for you, but also marking also helped me with actually getting, a better centration of the lens as well. When you make the incisions, it does invite a lot of bubbles, and so you have to get some viscoelastic. The SimulEYE folks do have a viscoelastic you can use, which is not, for human use, and it's fairly inexpensive. So I make my limbal marks there, and I'm using the cannula to help me find 180 degrees apart. So you can see the mark is right on the limbus, 2 spots apart, and they're about 90 degrees from my other incisions. This is 2.5 millimeters from the limbus. I tried to use a cannula tip to mark. This works in humans, but obviously it's not working on the model. So I'm going to have to use the ink pen. Again, these are 2.5 millimeters apart, and then the adjacent mark is 2 millimeters. Again, 2.5 millimeters posterior to the limbus. Now on the left side, I'm trying to find my spot. Obviously, it doesn't indent like a real eye. And then I'm going to go ahead and place that mark 2.5 millimeters posterior, and then 2 millimeters adjacent to that mark I just made. And this next mark is going to be for the anterior chamber maintainer. So again, the contralateral incision is right there. This is the main 3 millimeter keratoma incision there. That is the incision for the AC maintainer, 20 gauge Lewicki. And those lines signify 2.5 millimeters posterior to the limbus, 180 degrees apart, and this mark signifies 2 millimeters adjacent to that other mark. And that's going to be the point of entry for the scleral needle pass. So I go ahead and make my incision for the AC maintainer, and here it comes, again, 20 gauge Lewicki AC maintainer. It's a nice snug fit there, and it's got little ridges on it to help it stay in place. This is the right side needle. Again, 30 gauge thin wall, bevel towards me, about 80 degrees. You can see the bevels towards me. Again, the bevel faces the approach of the haptic. This is the left side needle, bent at the hub, about 80 degrees, and the bevel is facing away. This is a 25 gauge needle, again, contra-incisional, placing the lens through the main incision. My assistant is advancing the lens. As she does this, the leading haptic comes out, and I'm going to make sure that the leading haptic is docked on the bevel of the 25 gauge needle, which allows me to very gently and atraumatically externalize the leading haptic without grabbing it. Grabbing it can cause bending of the haptic or even distortion of the tip, which may interfere with its ability to be cannulated into the needle. I go ahead and take over and deliver the optic, making sure the optic comes out correctly, and then I'm rotating the trailing haptic towards right so that the optic comes out correctly. Injecting some more viscoelastic to protect the corneal endothelium. And this is the right side needle. I'm tunneling 2 millimeters and then entering and then sweeping across. You can see the bevels facing towards me. With very gentle pressure, I'm going to go ahead and internalize the haptic with the micro forceps, docking the haptic on the bevel of the needle, flattening it out and very gently internalizing the haptic into the needle. So again, very atraumatic, very well controlled by going after the trailing haptic first with this modification. Go ahead and loosen the syringe from the needle using the 23 gauge microforceps to internalize the leading haptic into the anterior chamber. Entering at that spot, tunneling 2 millimeters with the needle, and then diving in. You can see the bevel is away from me, which will again be facing the approach of the haptic, which allows easy docking. Grasping the haptic, even though I'm far away, it's okay. I'm going to dock it on the bevel, flatten it out, and as I'm flattening it out, it's going to advance very nicely. You have to have a very gentle pressure when you're dealing with these very delicate haptics. So I'm just going to pull it out again just for instructional purposes. Again, the haptic lands on the bevel of the needle, docked, and then as it's flattened out, then you advance. If you don't flatten it out and you try to push it, that's when you might bend the haptic. It takes a very gentle touch when you're doing this maneuver on these PMMA haptics. And then this is going to be simultaneous externalization of the haptics in the direction of the approach of its initial entry. And that's it. So you can see, since I marked it and I really went by the book, I didn't cut any corners. This is a very well-centered lens. You can see everything I'm doing. The only thing that's lacking on the video is the vitrectomy. I didn't have my trocar placed in this case. So you can see now I've pushed the haptics flush to the sclera, and you have a beautifully centered three-piece lens with the intrascleral haptic fixation technique. So this was the intrascleral haptic fixation technique using the Kim modified technique, aka trailing haptic first modification. Externalize the leading haptic using a 25 gauge needle to dock the haptic on the bevel of the needle. It's an atraumatic way to externalize the haptic. Before, I would use to grab it with the forceps, and there is a potential possibility of deforming the haptic with those delicate PMMA haptics. And so as a result, I do this other technique now where I use a 25 gauge needle to lead the haptic out. By doing it that way, you can go for the right side needle and go ahead and try to cannulate the trailing haptic first. This is much more ergonomically easy because the leading haptic is outside of the eye. It causes the optic to move up and away, which gives you a lot more access to the trailing haptic. Once you do that, you're able to internalize the leading haptic and go for the leading haptic, even though there's a little bit of tension because the trailing haptic has been docked, because all the action is contra-incisional. This makes this a much more easy approach. And as you saw, you're able to dock the haptic on the bevel of the needle, flatten it out, and straighten it out. So even though the haptic doesn't have a perfect approach to the needle, you're able to flatten it out and go ahead and cannulate it. Again, with the PMA haptics and the 30 gauge thin wall needle, it's actually a rather tight fit. And so unlike the C2 Lucia, as you're pulling out the needle, sometimes the haptic wants to just kind of slide back into the eye. I feel like with these haptics, they tend to be more adherent to the needle. And so as you're pulling them out, there's a lot more friction that's holding it in place, which is, of course, always good and reduces the risk of haptic slippage through the sclera. So again, this is using the SimulEYE model. This is the same model we use when we're teaching wet labs at Academy and ASCRS. And I feel like if you're going to learn this technique, this is really the best way to get started. You're going to do this on a model eye. You're not putting a patient at risk, and you're able to see a stepwise approach. Again, if you are new to this technique, I do feel like this particular modification is really advantageous, which has been shown with all the students I've had teaching the wet labs. Again, the masters of this technique all over the country are able to do the cannulation of the haptic through the needle with their own techniques. And that's because they're just very good at the technique. But if you are really learning, I do feel like this gives you a competitive advantage to be able to more easily execute the intrascleral haptic fixation technique. So I hope this was helpful to you, and I thank you for your attention.